Hello.
Sambadi. Yes, sir, we can see the screen and we are live now. Kindly go ahead. Thank you.
No, one sec. We are not able to see the screen. 1 minute.
Okay, sir.
Full screen. Can you see the screen?
Yes, sir, it is full screen. Perfect. Thank you.
Okay, we'll start.
Good evening, everyone. I'll be presenting Thursday cleaning for today. 4 years, 5 months old boy, third by birth order, born out of non-consanguineous marriage, resident of Bandra, Muslim by religion, Sheikh by community, informant being mother, brought with complaints of premature enlargement of penis and scrotum, noticed 6 months ago. Hair growth over upper lips, difficulty in walking since last 15 days, fever since 4 days, and headache since last 4 days. Child was all right 6 months back when the mother noticed enlargement of penis and scrotum around 6 months ago, along with pubic hair growth. 1.5 months later, mother noticed hair growth over upper lips and hoarseness of voice noted around 1 month later. Child was taken to outside clinic at Mandra, referred to ADIA for further evaluation, and blood tests and neuroimagings were also done, reported as normal with no treatment started. In May 2025, child was taken to his place in UP, shown to another clinician, and was advised some therapy for 6 months to stop the progression. Then father noticed difficulty in walking, requiring support since last 15 days. Child was swaying to both sides and was able to maintain balance. History of tremors of limbs aggravates on movement. Swaying worsened over 15 days, and child brought to Mumbai for further evaluation and taken to a hospital. Since last 4 days, low-grade intermittent fever subsiding on treatment. Headache since last 4 days associated with fever, frontal headache, moderate, and last still fever subside. Not associated with any head banging, nighttime awakenings, or vomiting. During the course of illness, child has become progressively less active and prefers sleeping. Child has intact appetite, communicates with parents, bladder bowel control is maintained, and is able to follow simple commands. There is no history of any abnormal body movements or focal neurological deficit. No history of visual disturbance or auditory abnormalities. No history of abnormal behavior. No history of any tuberculosis or TB's contact. No history of recent weight loss or similar family history. Past history not significant. ANC history uneventful. Birth history wise full term LSS with a birth weight of 2.75 kg. Cried immediately after birth with no NSU stay. Developmentally appropriate for the age and immunization till date. This is the dietary history with a calorie deficit of 200 kilocalories and total protein deficit of 7.
Okay. So 4 year, 5 months. So means roughly 4.5 year old. Premature enlargement of penis and scrotum noticed 6 months ago. So what that is the first complaint. So what are your thoughts on that? precocious puberty. So now two things here. The enlargement is precocious, that is for sure. But whether there is puberty also, so how do you decide that? So in other words, what is the normal sequence of puberty in a boy? What happens? What is the first sign of puberty?
Increase in testicular volume, followed by phallic length, and then adrenarche, hair growth.
What about voice? Hmm? Does change in voice also come somewhere? Where does it come?
Secondary sexual characters. Yeah.
Is it an early sign? Is it a late sign?
Late sign.
Okay. And so this is a premature enlargement of penis and scrotum noticed since 6 months ago. So this seems to be the first sign of puberty, right? Now, what are the other changes that happen normally in puberty in a boy? This you said. What else? When does the height spurt occur? Any difference in the height spurt in a boy versus a girl in puberty?
In boys, it's towards the end of it's in the end of the sequence, and in the girls, it's the earlier sign. Like after Thilati, it's one of the earlier signs, and then followed by Menarche. So it occurs earlier in girls.
Earlier means we have 5 stages. So which stage is in girls and which stage in boys?
Boys, it's the last.
Not last, 4. And in girls, 3. Okay, fine. So now, so this is onset of puberty. So what is the next question that you have to have in mind? Clinically, means when you are looking at such a child clinically, what are the thoughts or questions that you have to answer? So one is, this is premature onset of puberty. Second question in your mind?
Concordant is following the normal steps, sir. Discordant is one sign before the normal. So,
Very good. So concordant is what is following the normal physiological sequence, and discordant is not following the sequence. So a finding which should have come up later comes up first or something like that. What is the importance of this? Why should we know whether it is following the sequence or no? Anyway, premature puberty is abnormal.
It is a central cause. Mostly it will follow the physiological path, and if it is peripheral, so discordant will be more common.
Very good. So central will be concordant or will follow the sequence, and peripheral may not follow the sequence, right? Okay. Now you have hair growth on the upper lip. So what would that mean to you? Adrenarche. Then difficulty in walking since so far from these two, what have you decided? Okay, so the one more question should be there in your mind. What is that? You've answered 2. One you've said is whether it is onset. Then you've said whether it is concordant or discordant. Third, Come on. Whether it is isosexual or heterosexual. So you have both changes or you have any one same change, right? So that will decide whether the, what could be the various etiologies. So now,
So is it a pseudo precautious puberty or true precautious puberty? That also should come.
what is the difference between the two?
Pseudo precocious puberty more seen in case of obesity and
What is the difference? Can you have both? So from what I remember is that when you have a peripheral cause, it is initially pseudo. Then after a certain stage, that itself triggers the central hormones, and your central hormones also start increasing as if original true puberty has set in. So that is the true precocious puberty that is triggered by this peripheral precocious puberty, right? Okay.
Discordant and concordant, more or less on the same line. That means the testicular volume increase should come first and the other signs should come afterwards. If you see other things coming, but the testicular volume itself is not there, then it cannot be a true precautious puberty.
Okay. So difficulty, so this is done now. Difficulty in walking since last 15 days, for which obviously we need a lot of more details to decide where is the anatomy of this difficulty in walking, and fever since 4 days and headache. So let's see the details. So 1.5 months later, mother noticed hair growth and hoarseness of voice noted 1 month later. Child was okay. There is no, this is okay. There's no detail here. So child was swaying to both sides and was able to maintain balance. History of tremors of limbs aggravates on movement. Swaying worsened over 15 days. And why is icterus resolved? That's a misprint.
Actually, he was presented 1 month back with icterus, but it wasn't significant. So I have exactly 1 month back, he had icterus with SGOT LGBT derangement and total value of derangement.
Don't confuse with SGOT, SGPT. See, what have you told us that 6 months back they noticed in testicular enlargement. Then 1.5 months later, you said hoarseness of voice. Then in that story, difficulty of walking since last 15 days. Correct? So in that story, where does icterus come in? Or was there icterus at all?
Another infection 1 month back, and because of that infection, he had developed icterus. But I thought it wasn't significant, and that's why I removed it. But the line is still there.
Okay, so since you're hiding that from us, we will not discuss the icterus because it's getting very confusing. So we'll forget that. So now what do you make out of this difficulty in walking? Where is the anatomy?
cerebellum. There are swaying history, then there are a history of tremors.
Suppose somebody is weak. Suppose power is grade 3. Will that person also walk unsteadily? So why can't this be that? Means it is not cerebellar involvement, it is just due to power grade 3. I'm asking.
there is history of tremors, we can and aggravating on movement, maybe intentional tremor. Mm.
Okay, so suppose my hand is weak. Can my hand tremble when I'm doing some work? Yes or no? So how do you differentiate a trembling because of weakness and a trembling of a cerebellar or swaying?
Various tests like this, the kinesia or
Acute, acute history, then only on movement tremors increases. That would be it.
So swaying, you have to confirm swaying. What does swaying mean? What is the meaning of the word swaying? So there is a difference between unsteadiness due to power grade 3 and sway. So when there is unsteadiness, suppose I have my power is only grade 3. I take a step. I'm unsteady. So I'm unsteady means I'm about to fall. I'm not going to sway like this and sway like this. You're getting what I'm trying to say? So this swaying or going, suppose I'm walking like this. This swaying is cerebellar. So if you're actually going to the other side but not falling, that is cerebellar because that is a loss of balance. But if your balance is, you're not able to maintain just because of power, then with each step you will just stop short as if you are going to fall and then take the next step cautiously. You understand? So I'm just trying to tell you that remember when your hand has less power than what work you are going to do, then your hand does tremble a little when you're applying force. So when your hand has less power, it will tremble. But that trembling is different from this. Here you have to ask for that past pointing and all those features on history, which will tell you that this is cerebellar and not just weakness of the hand, right? Okay. So now, what do you think of this? So
And if there is too much of weakness in the legs, he won't stand only. Because he knows that he cannot support himself and walk. He may stand and not make an effort to walk. He may have difficulty in standing also. Because I know that I don't have power. Okay. So that also can, power is grade 4, grade 5, maybe he'll make an effort. Grade 3 may not even make an effort. He may stand and sit down.
so why is this cerebellar problem occurred now? We started with precocious puberty. We said that it may be central because it seems to be following the sequence of enlarged testis phallus followed by adrenarche. So we said it may be central. Now he's got cerebellar. So what is the possible connection?
CNS involvement mainly. Some space occupying lesion, tumors.
So how is that tumor causing cerebellar symptoms?
SOL can affect both cerebellum and pituitary. The case of the lesion.
So where is the SOL?
Posterior pituitary.
Okay. Okay. So do you think this is due to raised ICP? Is this cerebellar involvement due to raised ICP? What do you think? No? Why?
Yeah, if we think as well, if the size of the tumor is increasing, child may have raised signs of ICT along with all these symptoms.
Other signs of raised acidity like vomiting, headache, and other features are not mentioned.
Still he is maintaining sensorium.
So again, the point is that first of all, you don't have symptoms of raised ICT. Other symptoms like vomiting, headache, etc. Headache has come now in 4 days. We'll see what is that headache. We'll see the details. The second thing is that anatomically, a raised pressure causing cerebellar symptoms will be when which ventricle is tremendously enlarged. Which ventricle is near the cerebellum? Fourth ventricle. So fourth ventricle has to be tremendously enlarged to cause pressure on the cerebellum, to cause symptoms of cerebellum due to raised ICP. So that is like a very advanced situation. So that is why, since these symptoms have come up much ahead of other symptoms of raised ICP, this is not due to raised ICP. Okay. Now, since last 4 days, low-grade intermittent fever subsides on treatment, and headache since 4 days, frontal moderate, last till fever subsides. So what do you think of this headache? You have taken the history. So this headache is important or not important?
Yes, sir, it's important. Uh, because these symptoms are getting worsened day by day, and within 15 days, he had swaying. He's having headache. He's having fever spikes. Fever spikes could be due to infectious cause, but the headache we can't ignore. So
I know that we can't ignore headache. What I'm trying to say is, he has got headache now since 4 days, and you've written that headache lasts till fever subsides. So means after fever subsides, headache is there or not there? It's not there. So it is there only with fever. So what does that normally tell you? In anybody, suppose I get fever and I get headache and I vomit once, will you do my LP? Why not? You should do no fever, headache, vomiting, meningitis. So what makes you decide in a patient with fever and headache whether that headache is to be given the importance of a CNS headache? What makes you decide that?
He is lethargic, many convulsions, seizures, projectile warm. Signs.
Okay. So now let's make it a habit to learn everything very soundly. So when you said change in sensorium and convulsion, anatomically, when will you get change in sensorium and convulsion? Which part of the brain has to be affected? Cortex. So if with meningitis, if cortex is getting affected, it is advanced meningitis or advanced. So you have to pick it up before that, no? You can't wait for change in sensorium and seizure. Understood? So don't say that if a headache is not accompanied with change in sensorium or seizure, it is not CNS headache. You're getting what I'm saying? Because when change in sensorium and seizure occurs, it is too far advanced. You have to diagnose that headache before that as a CNS headache. So one point she said is severity. What else?
It should last, sir, and it is not relieved by medication.
Very good. So if you extend this statement, it also means that with medication, fever may reduce, but headache will not reduce. that tells you that this headache is not related to fever. But if fever and headache both reduce together with the medication, then the headache is likely to be due to the fever only, right? So here, if your history is right, then it seems that this is not due to CNS. But the problem is that your history is saying very low grade fever. Low grade fever does not cause headache. You understanding all the differences in the history? It is high fever which will cause headache with fever. Low grade fever, why should it cause headache? So either somewhere there is a mistake or somewhere the history has not been given properly, whatever, right? So either the fever has to be high grade, or if this is low grade fever and headache, then fever is not very important in this story, but headache is important because headache is severe, right? So then it may not be coming down with fever and it may be a possibly a CNS headache. Okay. Now, during the course of the illness, child has become progressively less active and prefers sleeping. What does that tell you? So now extend it further and think, no? Sensorium is going down means cortex is going down. So cortex is going down means very severe raised ICT. So what is not fitting with very severe raised ICT? Headache is
Irritable.
so 4.5-year-old will be irritable, yeah, because of the headache. What else?
There is no vomiting, sir, and headache is also not significant. It is not fitting. Mm.
So now start thinking laterally. Start thinking some other possibilities. They may be there, may not be there. But let's start thinking. So which system are we dealing with? Originally, endocrine. And you are saying there is a central cause for that endocrine problem. So now can you think some other possibilities? I'm just asking, making you think. A central problem which is causing some hormonal disturbance, can it cause some other hormonal disturbance is what I'm asking.
For the child to be less active, like if he's having hypoglycemia, yeah, cortisol is also getting affected. That might affect the activity of the child.
Okay. So theoretically, you're right. So you'll have to correlate it with history of whether the child is feeding, eating, or not eating. Secondly, again, remember, we've discussed this in our class some time back also. These metabolic disturbances, hypoglycemia, hypocalcemia, are they episodic events or they are continuous? My question is, can a patient remain hypoglycemic for 4 hours or 6 hours or 8 hours continuously? Why he can't remain hypoglycemic?
Other body will adjust and try to uh, compensate for the hypoglycemia.
So there is always counter-regulatory mechanisms, defense mechanisms to overcome that, whether it's hypoglycemia, hypocalcemia. So it's going to be episodic, and in that episode, whatever can happen can happen. You can get a seizure, you can become syncopal attack, weak, drowsy, whatever, but it is episodic. So this kind of a drowsiness is not due to hypoglycemia. I wanted you to say thyroid. If suppose he's getting hypothyroid, then he could become more sleepy. I'm just asking you to think, why is it not thyroid? First, I wanted you to think that. Now you tell me, why is it not thyroid?
Weight gain, history of weight gain.
SOL, and it is irritating and causing increased secretion of one hormone, it will also cause increased secretions of all the other hormones and not hypo.
Fantastic. See, काफी लगाना पड़ता है, तो ही तुम लोग आंसर देते हो. Fantastic. Logic, no? If one hormone is getting increased with more stimulation, why should other hormone go down? It at the most it will increase. So it can't be hypothyroidism. Very good. Now child has intact appetite, communicates with parents, bladder bowel control is maintained and is able to follow simple commands. So what does this mean? Bladder bowel is maintained means what? Spine at least is not there. So your cause of difficulty in walking is all central. So that we have agreed on, right? He's talking and following commands means what? Cortical function is good. So the inactivity is not due to the cortex getting depressed, which anyway we had ruled out, saying that it doesn't fit in with the rest of the story. It's not due to raised ICP that is cortex is getting depressed. We had already discussed that. So this fits in with that, right? Okay. Now, no history of abnormal body movements or FND means what? Focal neurological. So means what? Each one should give you conclusion. So what is the conclusion of each such question?
No abnormal body movements like there is no involuntary movements are present.
Yeah, so why did you ask that? What did you have in mind? And what does it rule out?
Basal ganglia involvement.
Very good. So you
And no,
it rules out basal ganglia. Now you had anything particular in mind why you wanted to ask basal ganglia?
there is a dystonia or like basal ganglia involvement will
No, but in this story of precocious puberty with some possibly central lesion, is basal ganglia involvement a feature of that? I'm asking you. You getting what I'm saying?
For anatomy, sir, we space of occupying lesion.
Okay, I'm not convinced, but anyway, I don't know why you asked for basal ganglia. History of visual disturbance or auditory. Why did you ask?
the occipital lobe is involved or like posterior fossa is involved. So
Okay,
that's
anything
why,
else?
yes, optic asthma is involved.
So
with
pituitary we are talking of, so optic chiasma. Very good. Then no history of abnormal behavior. For what?
like cortical involvement, like any uh,
Raised ICP. Okay. So abnormal behavior doesn't really come under raised ICP directly. Again, I'm not seeing the link. Some Kupia diagnosis and then you're asking all this. You'll have to justify all this in the exam. Okay. No history of tuberculosis and TB contact. So can tuberculosis cause precocious puberty? Hmm? It can. One case report in Lancet, 1932. What? How does TB cause precocious puberty? I can't think of any connection. I don't read Lancet so much, but I can't think of any connection. So talk of common things. Then no history of recent weight loss or similar family history. So why? Hold close. Weight loss for what?
It's a malignancy, considering if it's a
Considering that it's a malignancy. And family history similar.
Neoplasia be inherited.
So multiple endocrine neoplasias are inherited. Past history, all that is fine. Okay, fine. So what one history related to your chief complaint is what you have not asked, which we discussed half an hour back. That when precocious puberty or puberty started, voice change, he said, no change in voice. What else? Height increase we talked of, no? Whether his height has increased or no. So you should have asked whether he has suddenly grown tall recently. Okay? And that, so what Khare sir earlier asked about pseudo and true. So if his height has grown recently, it would have said that he has gone into true precocious puberty. So that also you might have been able to make out clinically, right? If we get that history. Okay. Come. So now tell us your overall impression.
So, 4.5-year-old male child presenting with precocious puberty, central with progressive ataxia and tremors, most likely intentional, along with without seizures or without any focal deficit, without loss of bowel bladder control, is most likely case of intracranial space occupying lesion, or by second DDS, a CNS TB with multiple tuberculomas. Multiple tuberculomas.
Okay, so you'll have to tell us clinically why you are thinking of that second DD and the third DD based on your story that you got. You may get anything on examination array, on investigation findings, but you should be able to defend it clinically. So why would you say in the history, what gave you any clue to tuberculomas or to TB in this child? In the history, was there any clue? No.
Cerebellar involvement and the worsening symptoms within last 15 days.
पहले क्या बोला? What involvement?
Cerebellar involvement, tremors and ataxic gait.
Yeah. So, but okay. So basically, I mean, what the way I would have said is that, see, logically, that raised ICP which we were discussing as a central cause or a central lesion which is causing this precocious puberty, logically, it should not have given rise to cerebellar symptoms. So that means you're possibly talking of two different lesions. One lesion causing that stimulation and the precocious puberty, and another lesion causing cerebellar symptoms. If we are talking of two different lesions, then all the etiologies or pathologies, which can have multifocal lesions in the CNS, they can come in for discussion. You getting what I'm saying? Not directly tuberculomas, right? What is the commonest way? Forget this case. What is the commonest way in which a tuberculoma presents to you? Seizure, right? So this child has absolutely no symptom to tell you that this is a tuberculoma, right? And tuberculomas need not have constitutional symptoms like fever for 1 month or loss of weight or loss of appetite or all that. So from this history, there is no such thing. So a better way to argue would be that this child has come with precocious puberty, most probably central, but there is no other history to suggest any raised ICP convincingly. And at the same time, there is cerebellar involvement, which is a bit funny. So whether there are two or multiple lesions, and by that yardstick, then which are the things that can happen at multiple places, then maybe your tuberculoma may stand. And autoimmune encephalitis, why did you say that?
Sir, before 6 months, MRI was done, and which was NAD, which was normal. So, but there was no drop in sensorium. So it goes against the autoimmune encephalitis.
6 months back MRI
Yes,
was
yes,
done.
yes. MRI was done, and
Means
it was
when he presented with the symptoms.
the first symptom. That time also the MRI was done, and it was normal.
So what is your comment on that? That the MRI was normal, so this could be autoimmune encephalitis. What is your comment on that?
Not developed lesion.
Lesion disease could be multiphasic.
Peripheral tumor.
Autoimmune encephalitis also presents with behavioral issues and maybe weakness, but there is no such history.
Correct. So what I would have said is that the first complaint of this child is symptoms of precocious puberty. So to take that first complaint as a manifestation of autoimmune encephalitis seems very unlikely. So typically autoimmune encephalitis would present with a slow subacute onset of behavior changes, mood changes, sleep disturbances, and then it may cause involuntary movements, and then it may cause many other things also by different area involvement. So that way the onset of the disease has not been like a autoimmune encephalitis.
Autoimmune encephalitis is associated with teratoma of testis or ovary, which causes peripheral precocious puberty rather than central precocious puberty.
Correct. So that's now the next thing. That so can you elaborate on that? What comes first there?
In terms of CNS, or we first comes the CNS symptoms, then the puberty sign.
Is it the puberty signs or you pick up the tumor? So first autoimmune encephalitis. One of the DDs in autoimmune encephalitis which you have to tick off is a gonadal malignancy, which on screening you pick up. So it doesn't come with puberty, no. Here to this fellow started with puberty, right? So even that is too different. You understand? So my point is that even for exam sake, suppose see there are many times when in exams the supervisor may be our friend and he or she will tell us the diagnosis. Okay. but let us learn to be able to give a differential diagnosis which we can only clinically defend at the end of history, not because investigation has shown some diagnosis, right? So here you would give the first differential, but at the same time, in the same breath, you will say that I am not able to explain any raised ICP, etc. So there are no definite signs of a intracranial tumor that I have got on history. And then you say that I cannot explain the cerebellum very properly. So whether there are two different lesions or one central and one peripheral. There also for precocious puberty, we've said central more likely than peripheral, but we've not ruled out that it cannot be peripheral. Correct?
So on examination, he was vitally stable with efebrile with a heart rate of 76 per minute, with a respiratory rate of 22 per minute, maintaining saturation with BP 100 by 60 and CRT less than 3 seconds with head-to-toe examination. Uh, uh, Head-to-toe examination, head circumference is, there is a macrocephaly with a head circumference between +2 to +3 standard deviation. Conjunctival contention and oral cavities, there is a poor oral hygiene with hirsutism present and pubic hair present. And phallus is a hyperpigmented with enlargement of, and the size is around 6.5 centimeter, which is larger for his age and well developed with the tanner staging 4 with pubic growth hair thick and coarse. This is the height is between the +2 to +3 standard deviation. With weight +1 to +2 standard deviation with head circumference +2 to +3 standard deviation, suggestive of macrocephaly. This is a systemic examination. Systemic examination. Higher mental functions are intact. The child is alert, oriented to time, place, and person. Speech is normal, no dysarthria is present. Memory is intact, able to follow simple commands. Cranial nerve wise. There is involvement of 3, 4, 6 with a bilateral eyes, concomitant squint, and convergent nystagmus is present. And there is a loss of nasolabial fold on the left side.
Wait. So what do you mean by a concomitant squint?
Uh, so
So for me, I'm not trying to finger you. I'm just trying to see that we all understand what we are speaking. So what is the other word for concomitant?
non-paralytic.
Non-paralytic. So you either have a paralytic squint or you have a non-paralytic squint, which is called concomitant squint. So what exactly happens in concomitant squint? Just your understanding.
So the squint will disappear with the movements of the eyes. It might disappear, but in paralytic squint or non-concomitant squint, the squint will be there. Uh,
Is that what we mean when we say concomitant squint or non-paralytic squint? What do we mean by that? So first of all, let's start with squint. What is squint? Then we'll come to paralytic and non-paralytic. Everything you can answer. Hello, what is squint? Basic question.
Sir, eyeball movement goes in other direction.
So both eyes are not moving concomitant with each other.
Yes, sir. Yes, sir.
बरोबर?
Yes, sir.
Asa, that it tells you squint.
Yes.
तर आता if I am looking straight, my one eye is looking straight, my other eye seems to be looking elsewhere.
Yes, sir.
That is basic squint.
Yes, sir.
Now, what will you do next to decide? So, suppose I am looking straight here, my right eye is looking straight, and my left eye is looking thoda idhar. Okay.
Yes.
So then you've got squint. Now you have to decide whether my left eye is going here because I have a medial rectus palsy.
Palsy.
You have to decide that.
Yeah.
To decide whether this is paralytic or no.
Yes.
So what will you do next? Before cover and uncover. So when you do eye movement in all directions, what will happen to this eye if it is non-paralytic? It will move full range, no? So in other words, a non-paralytic or a concomitant squint means that you see that there is a squint, but when you do eye movements, the movements are full in both eyes in all directions. So that is a non-paralytic squint, right? So that's our understanding of non-paralytic squint. Now in this case, did you expect a paralytic squint or a non-paralytic squint? Why paralytic?
If there is space occupying lesion, we expect cranial nerve involvement.
Correct. So now you expected a paralytic squint. So now there are two problems. Either our diagnosis of paralytic or non-paralytic is mistaken here, or what could be the other possibility? So when does that non-concomitant squint come? It comes at 4.5 years of age. Chalo yaar, please think.
Sir, it presents usually in early childhood because of accommodation defects. Which are
Whatever it
hyper-
is, so it must be there from much earlier. So your question has to be, ki, are these eyes like this even before the onset of this illness? Then, so means I'm just trying to say that nothing can prevent a child with concomitant squint to get this problem of precocious puberty. Correct? But then you have to ask, no, that whether this is there pehle se. And if this has happened now, then our diagnosis of concomitant may be mistaken. Understood? Okay. What is conversion nystagmus? I don't know what is conversion nystagmus. This term is a little confusing to me. Anyone wants to explain? What did you mean when you said that?
While accommodation, there is a fast component towards the medial side. So during like it keeps moving. While converging the eyes, like if we place one object near the patient, there is a squint, there is a nystagmus present.
Fine.
Sir, both
No.
direct directions of the convergence in same direction. They are coming together.
No, I understood. What he's trying to say is when the patient is made to converge his gaze to a near object, he's saying there is a nystagmus. Now, that's a little difficult. I mean, I haven't heard or read or seen this, that on convergence you get a nystagmus. That's why I asked him, is it one time or it keeps happening? Because maybe from whatever was his gaze, he may suddenly move his eye to converge. That's a one-time movement. That's not nystagmus. But nystagmus is he keeps moving like this. So
Whether it's, present on lateral movements or vertical nystagmus or lateral, and which is the component, where is the fast component. That is all about nystagmus. I don't know whether convergence produces. So
So, I mean, at the most, we can say that this nystagmus is cerebellar in origin, and he is trying to say that it is clinically visible only on convergence. Is that what he is trying to say? I don't know. At rest, what happens? There is no nystagmus. So, nystagmus is visible only on convergence. So, converge, okay, anyway. What about that nasolabial fold? So, loss of nasolabial on the left side. Do you think there is a left-sided?
Actually, actually it's since the birth only. Actually, mother was saying it's like that only. He smiles like that only.
Okay, very
But-
good.
But
Good you asked that. So again, let us keep thinking for every finding so that we are less wrong. So suppose there was a loss of nasolabial fold, what would it have meant to you? What would it have meant to you? Which one? Upper or lower? So upper motor neuron, facial nerve involvement. Now from whatever we are thinking, would you have expected upper motor or lower motor? Why?
नाही माहित सर नाही माहित
Because the pawns may be involved. Pawns may be involved. So it will usually involve lower motor.
So usually upper motor neuron is seen when you have a pyramidal tract involvement along with that. When we are discussing raised ICP, cerebellar tumor, things like that, tumor in the relation to the cerebellum and pons. So these are the nerve nuclei lying there, 7th nerve, 6th nerve, all that. So then it has to be a lower motor neuron, and then that whatever that concomitant squint should also be actually a 6th nerve palsy and a paralytic squint, if at all. So we need to check these findings.
you said that it's present from birth. What does it mean?
not since birth, but whenever mother has noticed that there's the problem.
What problem?
Like वो mother was saying कि वो हंसता ऐसे है एक साइड ये होता है.
So does it mean that it is a paralysis of facial nerve? What he wants to say perhaps is the last time we discussed was the absence of depressor angular muscle, in which if the angular depressor is not present, the upper lip is, the upper fold is not affected. It's only the lower fold is affected when he tries to smile or talk, because this is going down while this is not going down. But it has nothing to do with upper fold, which looks normal. So even if the mother says that, it doesn't mean that it is the facial which is involved.
Tone power reflexes. Tone is spasticity in bilateral lower limbs with power more than 3 by 5 in all four limbs. Reflexes are brisk all over, but more on the left side than right side. And clonus is present bilateral, well sustained on the left side. Plantars are extensors with bilateral cerebellar signs with pass pointing present and dysdiadochokinesia with nystagmus and truncal ataxia. Gait is broad-based and swaying to either side, unable to maintain balance without the support. And there is a lumbar lordosis present with no meningeal sign.
So what do you interpret out of all this? Cerebellum nahi. I want you to pick up something very big which has a lot of meaning. Spasticity means not necessarily cortical, but means pyramidal tract involvement. Did you expect it on history? No. So that's a big surprise. There is definite pyramidal tract involvement because there is change in tone, there is clonus, there are brisk jerks, okay, and bilateral. So now, what is the next conclusion out of this? Something very important that has come up. Multifocal, fantastic. So the problem is not at one place, the problem is at many places. Because you cannot connect so many things. You cannot connect central precocious puberty with UMN signs, with cerebellar involvement. So the pathology seems to be involving multiple areas, right? Very good.
Other systemic examinations are within normal limit. Investigations were done, which were within normal limit only. And then the MRI was done. There is a 6 by 6 into 6 by 4 into 5 centimeter size well-defined solid cystic lobulated lesion with multilocated areas of hemorrhage and calcific foci within the lesion is noted in the region of pineal gland, tectal plate, and posterior aspect of third ventricle. On post-contrast study, the solid component shows mild heterogeneous enhancement with peripheral enhancement of the cystic component. It is causing complete obliteration of the bilateral crural, ambient, and quadrigeminal cisternas, resultant moderate non-communicating hydrocephalus with mild periventricular roots. A large component of the lesion measuring this size, a long superolateral aspect extending into the body and part of the occipital horn of the right lateral ventricle via foramen of Monro with minimal displacement of the septum pellucidum to the left side and subependymal periventricular heterotropia as described. And about described findings is suggestive of neoplastic etiology of pineal gland. The DDs are pineoblastoma, germ cell tumor, and pineal parenchymal tumor of intermediate differentiation. The child currently is in the neurosurgery department, and the EVD has been placed because of the raised signs of ICT, and the further management is going on.
So all the cerebellar and the pyramidal tract signs are all due to raised ICT. That means. So there was a large hydrocephalus, no?
Yes, sir. The EVD was also placed today morning only.
So we discussed that if cerebellum has to be involved, then it has to be a huge dilatation of the fourth ventricle to cause cerebellar involvement. But what was surprising was there was no clinical signs of that kind of a raised ICP. Your history of no vomiting is definite.
No vomiting. There was no vomiting.
And headache only lasts 4 days.
Yes, had headache. Yesterday also he's having headache, but had fever spikes also. And he had raised signs of ICT. We started him on 3% NaCl and dexamethasone.
What raised signs he had?
Sir, he had bradycardia with with a heart rate of 56 per minute, and the BP was on the higher side with more than 90th centile.
When he came, his heart rate was 56.
No, sir. When he came, the heart rate was 80 to 90 around. But yesterday, there was a deterioration in the sensorium also. We have the video of the child also with that broad-based gait. But today morning, the sensorium dropped suddenly.
So this MRI is done when?
On Monday.
Before the sensorium drop.
Yes, sir.
Okay. You have the.
I couldn't play
Yeah.
the video here actually.
लैपटॉप के कैमरा में कैसे दिखेगा? इधर इधर इसके कैमरा पे इधर बोल रहे Our online viewers,
Hi, Rajesh.
no, any comments, any questions, any?
Excellent case, good presentation, well discussed. Only I'm wondering how come the first neuroimaging was absolutely normal, or did they just understand that it was normal?
So we don't know that. And I mean, giving the benefit of doubt, maybe the lesion at that time was small and therefore missed or whatever, but we don't know that.
Yeah, because it was so sad that although child went to a good hospital and neuroimaging was done, it was missed. So whether also CT scan was done, I think. So whether MRI is a good modality and not CT scan for detecting tumors.
Okay, he's showing the thing in that cyan wala video. Just see there the.
Yeah. अजून एक देऊ तिला नाही नाही तेच ते तोंडात काढत होते ना ते गिळायला ड्राय आहे ना
Fine. Yeah, Palni has said that in boys, precocious puberty is always pathological. In girls, sometimes you may not find a cause, which is true. In this case, I think what we were kind of uh, confused is that for cerebellum to be involved, there had to be a huge amount of hydrocephalus, and for that, the symptoms other than the precocious puberty were very few. So that's why we were thinking of multifocal lesions, right? Okay, fine. Anything else? Palni, Anjali, anybody on online? Any questions? Any comments?
No, nothing.
Okay. Yes.
Sir, about that symptom which sir mentioned, that convergence nystagmus, sir, means I remember reading, sir, it is seen in a syndrome called Parinaud syndrome, that convergence retraction nystagmus, sir. On upgaze, you get towards the center as if you are converging, you get a nystagmus, sir, and it is seen in midbrain pathology, sir, mainly pineal gland. So that is actually could be an important clue to the diagnosis, because in the MRI, sir, pineal gland tumor is
Okay.
one of the.
Yeah, good. Now that you say, I vaguely remember that. I agree with you. I'd forgotten it because we don't see it. But now when you mentioned it, I remember reading it long back. So you're right. So I think that was a clue. So you should have told us that.
An important thing to be remembered, which is often missed, is whenever there is a central tumor, pituitary, pineal body, often the field of vision is affected and a perimetry is affected early, and commonly perimetry is not performed. We may at the most by clinical method try to see whether the peripheral field is affected, which is not. I distinctly remember one or two cases where the patient was taken for a routine examination and the ophthalmologist was smart enough to do the perimetry, turned out to be pituitary tumor, operated. It's 10 years now that the patient is still normal. So it was an early detection. So perimetry is one thing which is forgotten. Even if you are not an ophthalmologist, some idea about perimetry and vision, which we often don't do that. Dikhta hai, nahi dikhta hai, we bring it back, is to be remembered.
Okay, fine. Thank you. We move on to the second case. Treatment.
We don't know the diagnosis. Actually, decompression will be the first step to be done. We'll get to the neurosurgery.
Good evening. My patient 2-year.
One. The new slides are visible.
Yes, yes, Rajesh.
2-year, 10-month-old male child, second by birth order, born of third degree consanguineous marriage, hailing from Solapur, Maharashtra, Muslim by religion, Sheikh by community. Brought my mother with the chief complaints of yellowish discoloration of skin and eyes since 27 days, abdominal distension since 25 days, and fever since 15 days. Mother noticed high colored urine for 2 days, following by which she noticed yellowish discoloration, which was insidious in onset and gradually progressed to involve skin also. Then 2 days later, she complained of swelling in bilateral lower limbs, which was insidious in onset and gradually progressed up to thigh, then developed abdominal distension and then facial puffiness. The swelling had no positional or diurnal variation. Abdominal distension on inquiry was noticed by mother, more in upper abdomen, no vexing and veining present. Child received Ayurvedic medications for above complaints for 3 days. Then child was admitted for around 20 days in Solapur, received ADK supplements, IV antibiotics, diuretic. He also received multiple PRC transfusions there, and mother told that the child had low blood hemoglobin even post transfusion. After 5 days of admission, child developed fever, high grade, relieved with medications, active and interfebrile period, associated with chills and rigors, and not associated with any rash. There was history of increased sleepiness and decreased activity, history of decreased oral intake, no history of outside food consumption, no history of vomiting, abdominal pain, no history of melena, hematomesis, no history of clay-colored stools, pruritus, increased work of breathing, no history of weight loss or loss of appetite, no history of COX or COX contact, and no history of blood transfusions in past. There's no history of any past admissions. ANC, there's history of blood transfusion in mother at 7 months of gestation, rest uneventful. Birth history, full term, vaginal delivery carried immediately after birth. Birth weight of 2.5 kgs, no history of an ICU stay, and history of neonatal jaundice on day of life 6, received conservative management. Received birth vaccines, immunized till date. Developmentally appropriate for age. Dietary has a calorie deficit of 150 kilocalories per day, per kg per day, and and protein deficit of 3.5 gram per day. He has an elder sibling who's normal, 2.
Okay. So the first complaint is yellowish discoloration for 27 days. And started with high colored urine followed by yellowish discoloration, which gradually progressed. So what is your analysis of this? Where is the anatomy? Liver or hemolysis? Why?
Very.
Why liver? Why not hemolysis? That has not come still. We are only on
No acute cause for any hemolysis, no, not present since childhood, no blood transfusion histories.
High colored urine.
fantastic. So high colored urine means conjugated jaundice, which means this is hepatobiliary. Don't say liver. Hepatobiliary and not hematological. So that is the first step. Okay. You have to confirm all this. So you have to double check that okay, urine was high colored. Okay. Now, in hepatobiliary, hepatic means hepatocyte disease or biliary tract disease? What do you think? So how do you decide, or in other words, what are the other symptoms of hepatocyte dysfunction? So if they are there, then you will call it hepatocyte disease. If they are not there, you'll ask yourself, is it biliary tract disease? So what are the symptoms of hepatocyte dysfunction?
If he had a history of pale stools, then whitish pale stools, then it would have been a hepatobiliary disease of the biliary tract, somewhere obstructed.
Yeah, so you're right that if we had a history of pale stools, it would mean biliary tract obstruction. Now here you have to remember two things. For getting pale stools, how much obstruction should be there? Little or almost complete obstruction?
It was complete.
Complete obstruction. And the second thing is, what is the age of this child? 2 years. So when we get it in the newborn period, we are thinking of congenital problems. We are thinking of extrahepatic biliary atresia. That's why you are getting pale stools there, and that's why that is a very important presenting complaint or part of history. Here, in an older child, you can get pale stools, but it is not as common as in the newborn. So you don't depend on it to decide whether this is biliary or hepatocyte. Get my point? What else? So acute hepatocyte dysfunction, what will be the symptoms? GI symptoms like
Vomiting, loss of appetite.
acute. So acute hepatocyte dysfunction is nausea, vomiting, and loss of appetite, anorexia, and soon followed by jaundice. So this combo, anorexia, nausea, vomiting, soon followed by jaundice, is the typical symptom of acute hepatocyte dysfunction, right? You said later followed by swelling, ascites. So do you get ascites in acute hepatocyte dysfunction? Why do you get ascites in liver disease? What is the pathophysiology behind getting ascites in liver disease? Piche, we'll come to.
Albumin synthesis is decreased.
Excellent. Albumin synthesis is affected. So that is going to get affected in acute disease or chronic disease? Very good. What is the half-life of albumin? Hours, days, weeks, months. Number जाने दो. Okay. चलो आवर्स और मंथ्स. अभी अमिताभ बच्चन के जैसे दोनों एलिमिनेट करते, तो अभी वीक्स और डेज बचा, उसमें कौन सा? So 26 days is the half-life of albumin. The point is that in acute hepatocyte dysfunction, in acute fulminant hepatic failure, you may get ascites. Otherwise, usually you don't. That is one mechanism of ascites in liver disease. What is the other mechanism? One is, you said very nicely, low albumin. What is the other mechanism?
Portal hypertension.
Excellent. So portal hypertension. So what does portal hypertension do? It localizes that fluid to the peritoneal cavity. So because of hypoproteinemia, you are liable to extravasate in the ECF anywhere in the body. Now, which area does it choose? It chooses the peritoneal cavity ascites because of portal hypertension. So that's the combo, right? Okay. So So in this case, we need to know specifically whether, or we have to always ask whether this high colored urine was preceded by nausea, vomiting, anorexia.
Was not.
It was not. So what does that rule out? So it rules out infectious causes for sure. So remember this, that infectious hepatitis means viral A, viral E, all those have to have a prodrome of nausea, vomiting, anorexia before the jaundice comes up. They must. If they don't, then you don't rule out acute completely, but infectious is ruled out. So now to give you an example, Wilson's disease may come with suddenly jaundice, acute onset of jaundice, which is acute hepatitis in Wilson's, but it is minus the nausea, vomiting, anorexia, right? So if you get such a jaundice, you start thinking of metabolic, drug-induced, etc., non-infectious. Okay. So now you said 2 days later, followed by swelling of both lower limbs, and then gradually progressed, and then progressed over how many days? Any idea on that?
She noticed over 2 days only. That 2 days.
Correct. So 27 days back jaundice, 2 days after jaundice swelling, and within 2 days the swelling increased all this to abdomen and everywhere. Within 2 days.
Was noticed more in thighs and not ascites. That is what it means. It started with swelling of the lower limbs, which progressively increased upwards and did not start with ascites. So what does that mean? We saw that hypoalbuminemia may be the important factor in production of edema, and hypertension only helps to localize the fluid into the abdomen as ascites. But here it has started lower down. So can there be any other cause? Such as jaundice is already there in this child. Okay, anemic failure, but when there is jaundice here, other respiratory signs will come up. You will have so much cardiac failure that edema has occurred as a presenting manifestation. There should be associated other signs that have come earlier, like increased tolerance to exercise, etc. So if hypoalbuminemia is the cause, but not the side, that means portal hypertension is not a very major factor, which may help to localize the lesion, fluid to abdomen. And hypoalbuminemia may be there in the absence of a significant portal hypertension, which is presenting down. Is there any other cause also? Child with abdominal distension, there may be no icterus and progressive swelling of the lower limbs. Child presented with abdominal distension and swelling of the lower. A renal cause, why should it give rise to ascites first? Renal cause will often give rise to puffiness of face. Pardon me? No, kwashiorkor will have a lot of mental changes. Ascites is not the presenting. Can you think of something which is obstructing the flow of the blood and has given rise to hepatomegaly and also peripheral edema? Can there be any vascular cause? Budd-Chiari syndrome can present with acute ascites and hepatomegaly, and there may be associated lower limb problem also. Here there is no ascites here, there's only lower limb problem. So in Budd-Chiari, I would have expected abdominal distension followed. So here probably hypoalbuminemia is the main contributing factor without significant portal hypertension as is there in this particular child.
So again, your history needs to be, so we need to first understand why we are asking any particular history, what is its importance to us, and then we will be able to take a more definite and a more confirmed history. So now you have mentioned that the swelling progressed and then developed abdominal distension and then facial puffiness. And then later you have said that distension was upper abdomen. So if distension was upper abdomen, then there is no fluid in the abdomen, right? You're talking of organomegaly only, right? And logically, do you think that hepatocyte dysfunction in the form of hypoalbuminemia will come up first and then you will get abdominal distension due to organomegaly? Do you think that will happen? So if it is organomegaly and like we said, it is chronic, then that abdominal distension has to be there much pehle, right? And just now, because this child has got into swelling post jaundice, it could well be that hepatocyte function is going down. In which case, then it has to be distension of abdomen all over, not upper abdomen, because he has to develop ascites as a part of his hepatocyte failure. So you're getting what I'm saying, that the parts of the history are kind of not fitting with each other. So once we understand why we are taking that history, we will next time try to dig it in more detail. Okay. Now let's discuss both the options. Suppose the hepatocyte, so now we are saying this might be chronic. So what history do you want to decide whether this is chronic or no? This whole problem, we started by saying that if he has developed edema feet due to hypoproteinemia, then it is likely to be chronic, more likely chronic than acute. So how will you decide on history whether it's chronic or no? Duration, so whatever is given, less than 1 month. Something you have to ask about the first 2.5 years, which will tell you whether this is chronic or no. Exactly, growth of the child. So every time we have been learning that we must ask that was this child absolutely all right before this 27 days? Was he active, playful, eating well, growing well, all that? So what is the answer? Did you ask that and what is the answer?
It's all right. 1 month back.
He was
Constitutional symptoms, not doing well, not playing.
playing, eating, growing like other children. So now what does this tell you? Is it a chronic disease or no? Huh? It's not a chronic disease. If this history is correct, then it is unlikely to be a chronic disease. Secondly, chronic liver disease to go into hepatocyte failure so soon at 2.5 years is also a little unusual, right? There would be some past history of some event, etc. At least some jaundice in the past or something, right? So now we've said it is not likely to be chronic. We've said history is not supporting that. We've said it doesn't seem to be infectious. Age also is not right for infectious and there is no nausea, vomiting. So which other acute can come like this? So we said none, either drug induced or metabolic. So metabolic disorders can come suddenly and they can go also severe if there is more than one insult. So there is a original metabolic problem and there is a add-on insult like some infection, then they can go suddenly down. So if there is no past history, if it is absolutely clean before this onset of this illness, and this illness is suddenly going down into so much of edema and all that, and ascites we are not sure because your history is little confusing. then whether it is a metabolic disorder. Now, also you have to correlate the severity of the hepatocyte function going down with other symptoms. So we said onset nausea, vomiting is not there, so non-infectious. But imagine somebody's liver function is going down drastically. How will you find out on history in other ways that his liver function is going down drastically? Rapidly progressive, how will you find out on history? One is bleeding manifestation. So are there any bleeding manifestation? No. Then encephalopathy. Is there any encephalopathy?
History of increased sleepiness.
There is some history of increased sleepiness. Since how many days?
20 days, 1 month.
Right from the beginning, there is history of increased sleepiness.
It is irritable now. The irritability has increased now. But at presentation, he had increased sleepiness and drowsiness.
So at presentation means how many days after the jaundice was he sleepy? He's saying at the beginning.
It is preferring to sleep, but he's eating and all fine.
So that is not encephalopathy. If he's preferring to sleep but eating fine and all that, that is not encephalopathy. Okay. How else would you clinically pick up rapidly progressive liver disease, hepatocyte disease? So vomiting should come up now, no? Even if it was not there at the beginning, they are bound to be vomiting and not being able to eat and retain anything. If it is a rapidly progressive hepatocyte disease. And most important, very deep icterus, progressive deep icterus. So how severe is the jaundice according to them over these 20 days?
Initially, mother didn't notice. People were telling her that बच्चा पीला हो रहा है, but she didn't notice. Then, first she noticed in the eyes, and then skin was also involved, and it increased only. The pictures was like it was progressive only.
Now, for a minute, because there is so much of kind of, if I can say so, little gaps in the history. Could this be not a liver disease at all? Come back to the original. Could it be a hematological disease where he's getting into progressive pallor and now he's gone in failure? That's why edema fit. Only one thing may be wrong, high colored urine may be wrong. Then it fits into progressive pallor and cardiac failure. What do you think?
It might be because the child has received multiple transfusion in the 20 days. On presentation, child presented with failure.
You are saying he presented with failure or you are asking?
Hospital, he presented with signs of failure. Along with that, he had complaints of.
So that's what my point is. Now, I was trying to tell you that when you are saying that he looked, mother did not notice, others said he is pale or he is yellow, that complaint is actually pallor. When others say that your child is looking yellow, it may be pallor because mother did not notice yellow. That is one thing. Second thing is that your distension that edema ka history is very funny. We discussed how it is not fitting with we said chronic liver disease bhi nahi hai, acute bhi nahi hai, so where is it? So that was the problem. And the third is that uh, you have to ask for history of breathlessness. So you are saying child presented with symptoms of failure at the first hospital. That means child was breathless that time. So you've not mentioned anywhere that the child was breathless. We have to ask for history of breathlessness. That will be the clue.
There's no increased work of breathing.
How can you be in failure without increased work of breathing?
There was intolerance. He used to become breathless first. There was increased, I mean, he was easily susceptible to becoming breathless. Exercise, activity, he would restrict the activity because he would become breathless. He was inactive physically for a few days, in which case you can anticipate a slowly progressive pallor and a failure. It cannot be acute liver failure. I'm sorry, cardiac failure. But your first sentence of high colored urine, and it always
So then
takes
that,
us afterward.
that high colored urine, it also is kind of misleading, no? So this could be just pallor and failure. Okay. Now take that further. What could be the cause? See, because history is not clear now, we are not able to decide on one or the other. We have discussed the liver and the hepatobiliary part, whatever is possible. Assuming that this is progressive pallor and now he has come in failure and edema, what could be the cause of that at this age? Viral infection causing progressive pallor and failure. So first of all, is it acute anemia, chronic anemia? Hmm? Why acute? One is he was all right before. Second,
It was chronic disease and child would have adapted to the low hemoglobin.
fantastic. Why should a chronic anemia get into failure? Okay. And so much failure to get so much edema and all that. So therefore, child would have got adapted. So this is a acute progressive anemia, if it is an anemia which has gone into failure. So what is the cause of acute progressive anemia?
Hemolysis.
So what could be the reason?
Can it be hemorrhage?
No, like, there is
It would
no
be
logic.
obvious if he has bled anywhere, and he would be rather in shock with acute hemorrhage rather than going in failure. Okay, so acute hemorrhage would be in shock. Acute hemolysis, depending upon how it will give rise to progressive pallor. His high-colored urine was persistent throughout we don't know that, because that's what took us right away in the beginning to something which was hepatocellular jaundice. We don't know that, so we take that as probably not important, and we come to pallor as the main symptom, and it has developed over a period of time requiring transfusion repeatedly. He has received transfusion earlier also in another hospital. No? Before we also received multiple PRC transfusion, and mother told that the child had low hemoglobin even post transfusion. So he had multiple transfusions earlier, only 20 days old.
So we have come down to hemolysis as a cause. What is the cause of hemolysis? So she said viral. No, viral you said for hemolysis. Give me an example.
Parvovirus.
So parvovirus, does it cause hemolysis? it causes bone marrow suppression, right? And that will not come so acutely and so progressive to cause in 20 days failure, right? And secondly, that happens to children who already have a hemolytic disease. So they have a kind of a crisis situation, right? A normal child getting a parvovirus infection and bone marrow suppression will not come like this.
Causes of acute hemolysis might be a reaction to a drug or G6PD deficiency is there. So acute hemolysis can be due to that, or maybe something infectious like malaria can also cause.
Fantastic, fantastic. So, drug-induced G6PD, malaria, autoimmune hemolytic anemia, these are all your causes of acute hemolysis, which can be progressive and can lead you to this situation. Now, the problem is for it to be drug-induced, that original drug means at the beginning of that 27 days when the paleness started, that original drug has to be taken for some complaint, no? What was there? Was there some complaint for which a drug was taken? If no, why would anybody take a drug which can cause hemolysis? You get my point? So that is missing here. Now, for malaria, again, there is no fever at the beginning of the illness. So that is missing or odd for malaria. You can get malaria without fever in highly endemic areas, hyperendemic areas. Fever may be very low, but they will not have so much hemolysis and go down suddenly so much, right? So all that is also not fitting in. I think there are some gaps in the history. We've discussed both sides, the hepatobiliary side and the pallor and hematological side. There are gaps both ways.
Yeah, G6PD, sir, sometimes consumption of certain foods like fava beans and all also not very common and remote
Yeah.
possibility.
So
But
my perception is that all that is written in the books, but I don't think that it comes so acutely and so severe clinically, right? History of increased sleepiness, decreased activity, decreased oral intake, then all this is none. Okay, then there was none. Now quickly tell us the provisional diagnosis and your
2.5-year-old male with complaints of jaundice with abdominal distension with anasarca, with history of multiple PRC transfusions with third-degree consanguinity, second-born child, in a developmentally normal and immunized till date child is probably a case of chronic liver disease. On examination, child was febrile, pulse rate of 114 per minute, regular in rhythm, normal in volume and character, equal on both sides, no radial delay or radiofemoral delay. RR of 26 per minute, regular rhythm, saturation was maintained 99%. Peripheral pulse is well fed, extremity is warm, BP was maintained between 50 to 90th centile. On head to toe, jaundice was present, pallor, there were dental caries, abdominal distension, tests were normal and no signs of liver failure, no PTK purpura rash was there. Anthropometrically, moderate acute malnutrition present. On systemic examination, umbilicus inverted, distension present and more in upper abdomen. On palpation, abdomen was soft and non-tender, liver of 6 centimeter below right subcostal margin, firm with rounded borders, left lobe also palpable of 3 centimeter, liver span of 10 centimeters. Spleen 3 centimeter, grade 2 Hackett's classification and firm in consistency. No free fluid present and bowel sounds heard. Test of the systemic examinations within normal limits. Diagnosis is 2.5-year-old male with complaints of jaundice with abdominal distension, and then asarca with fever with history of multiple PRC transfusions, with hepatosplenomegaly with anemia, In a developmentally normal immunized late child is probably a case of chronic liver disease to rule out autoimmune hepatitis, Wilson's disease, a secondary HLH. These were the
So what do you think? Wilson's is possible at 2.5 years?
Autoimmune hemolysis that can sometimes be present which in pallor in 2.5 year, over 4.5 years, we can understand presenting with jaundice, and but 2.5 years for Wilson, I thought was little less. Even little later, 5 years, 6 years. Acute hepatic autoimmune hemolysis is known. One of the adult physicians told me a fact that often they see autoimmune hemolysis present in Wilson's disease, which may be a manifestation which is often not thought of, because we have to find out the cause of anemia also. Recurrent anemia.
They have found newer mutations because of which you can get Wilson's even before the age of 5 years. So our earlier learning, we think after 5 years, has changed. Whether we can get it in such a big way at 2.5, I don't know. But there are newer mutations which will cause it.
these were the investigations done in Solapur Hospital.
No, so tell us the gist, because we no, what happened at Solapur on presentation? What was the thing?
He had anemia
How much?
of 7.6 hemoglobin.
Huh.
And on presentation, he had counts of 14,000, but later pancytopenia was there. On receiving blood transfusions also, acute drop in hemoglobin was there. Initially, it was 7.6 hemoglobin, then transfusion was done, developed to 9 ka hemoglobin, then later again dropped down to 7.9. And the last hemoglobin they were documented was 5.65. So despite of three transfusions, the hemoglobin kept. He presented on 5th July, and the latest was 25th July.
So what does this tell you? Suppose you have a low hemoglobin, you transfuse and hemoglobin again comes down. What does it tell you?
Bone marrow is in.
Ongoing hemolysis. Bleeding.
Both bleeding, which is occult, or ongoing hemolysis. So ongoing hemolysis, what could be the cause? Again, autoimmune. Na? If you are giving transfusion and getting destroyed, then likely to be autoimmune.
The latest 25th July labs में pancytopenia is there. The platelets of 76,000 and hemoglobin of 5.65 and counts of 5,000.
And what was the bilirubin when they went to
On
Solar?
presentation, bilirubin was 9.5, 5th July. Then it was
Direct, indirect?
direct is 6.5 and indirect is 3.
OTPT that time?
185 and 135.
And proteins and
Total protein is 4.5. 4.5 and 2.5.
and PT, prothrombin time?
16 and INR is 1.18.
So what do you make out from this? This of a LFT at that time, what do you make out? Acute liver disease or chronic liver disease?
Chronic.
Chronic liver disease, right? Okay. So chronic liver disease with pancytopenia, with autoimmune hemolytic anemia mostly, right? Okay. So Wilson's actually is a possibility, but okay, go on.
The other workup was also done. Triple H was done negative, urine RM NAD, and
Hold like this. Forget
Ferret-
negative, just tell us
ferritin
positive.
was done, which was more than 2000, and triglycerides were done, which is 637. So they thought of secondary HLH.
Secondary to what? What was the primary illness?
That
There is no clinical primary illness only, no? So why are you saying secondary? There should be some clinical illness which is primary, no? And what ferritin is kind of strong suspicion of HLH? 2000? 5,000 or more strong suspicion, 10,000 diagnostic. But below 5,000, it could be multiple reasons. I'm not saying here. You have to look at it in a context, but less than 5,000 ferritin, it could be other reasons as well. Okay, fine. Then
CT showed gross hepatomegaly with mild periportal hypodensity and mild gallbladder wall edema, suggestive of hepatitis in appropriate clinical and lab settings, moderate splenomegaly, and mild ascites. Here CVC suggestive of hemoglobin of 8.7, hematocrit of 24.1, total counts of 2000, and platelets of 22,000. And RFT PTANA was normal. Serum ammonia was done, which is 60. Serum LDH 1284. DCT ICT was negative. LFT TBL of 17.3. Total bilirubin, direct bilirubin of 12.3. OTPT is 324 and 128. ALP of 166. Total protein 4.7. Albumin 2.5. OSG suggestive of hepatosplenomegaly and ascites nil. This was a Doppler done, suggestive of hepatic artery upper prominent. Then the bone marrow was done. It is suggestive of home cell scene. So pseudo cultures they suspected.
pseudo gouchers.
It is the foam cell scene.
They said that probably it was Gaucher cells only. Pseudo Gauchers was written by mistake. That was foamy cells and Gaucher cells were seen. So they then suspected it could be a story. So when the kid was brought to us, he was actually, after all the workup was done, they even did a autoimmune hepatitis ka panel. That was also normal. And for Wilson's, they had sent serum ceruloplasmin, which came out to be normal. And when they had sent, they could not think of anything. He was actually sent for a liver biopsy, probably. So when he was sent to us, we initially thought of secondary HLH also. So to rule that out, the bone marrow was done, on which we saw the foamy cells and Gaucher cells. So now we're thinking, like, after the biopsy report, we are thinking on terms of storage disorders, but the clinical presentation never matched that of a storage disorder.
Anything more on this? Fine. So I think every time, I mean, at least what we have learned is our discussion of about liver disease, and we were trying to debate there is inconsistency in the hepatocyte dysfunction that we were discussing. We said without nausea, vomiting, it has to be a metabolic cause of hepatitis. Then here we talked of hemolytic anemia. So the picture of hemolytic anemia was consistent. We discussed that we don't know why there is a sudden acute hemolytic anemia. So that we didn't know. The bone marrow, meaning HLH, if at all, it will cause falling hemoglobin, etc. Like I said, you have to have some illness. So this last 5 days ka high grade fever which you said, that could well be HLH. And you think of that. But then all the hematological complications should have happened in that phase of that last 5 days of high fever, not when he presented in the beginning.
So he started having fever spikes
चल,
after.
इसका हाथ धो ले प्लीज। यो अंगे हाथ धो ले पहले। सब नीचे हाथ लगाया और अभी मुंह में डाल रहे हैं। जा हाथ धो ले।
So initially, when he presented to the first hospital, 5 days of that admission, he started having fever spikes. The fever spikes have persisted from then till now. He's having high grade fever spikes for the past 15 days. And the first CBC that he had, usme usko 7.6 ka HP tha with high counts and all. After, like, it sort of correlates the duration when his HB started falling and the count started falling with the time that he started having fever spikes. Well, be because of
You didn't give us that history. You said Pele 27 days, all jaundice, pallor, transfusion, edema, and last 5 days fever. So then
50 days from now, he's had fever spikes.
anyway, so we learned some things here and there scattered. We did not construct the case successfully, but doesn't matter. We learned some things here and there scattered, right? Okay. Anything else? Final as of now is storage. Now they have to follow up on Gauchers and maybe get a gene diagnosis or something.
राजेश
Sent parvovirus and the Epstein-Barr virus. Then we are planning for sending NGS.
Yeah, Anjali.
I just looked up Google and it says that yes, Gauchers can cause both hemolytic as well as autoimmune hemolysis, as well as non-immune hemolysis. So in very rare cases, autoimmune is known in Gauchers as well.
Sure. Any other inputs from any of our online friends? Okay. Okay, so we'll stop here. Thank you very much for joining in. Thank you.